To start off this session with just giving you a few brief information on where we stand in Romania regarding HIV and viral hepatitis. I have no conflict of interest to declare in relation to this presentation. So we have to keep in mind that when we talk about Romania, we're actually talking about a population of 20 million people. And here we see a prevalence of 0.07% HIV infection, and each year brings along roughly 400 new cases of HIV infection in Romania. When looking at HBV, we see that the prevalence is 5.6%, and this is closely related to the national vaccination regimen. 20 years ago, back in 1995, Romania has introduced vaccination in all newborns and has implemented subsequent catch-up campaigns to vaccinate all children up to 9 years of age, and then all people up to 18 years old, and of course all healthcare workers. And here we are 20 years down the line. After 20 years of successful vaccination, we see that the decrease in HBV incidence in Romania has decreased 21-fold. Because for HCV there is no available vaccine, the prevalence has remained somewhere below 3%, roughly at 2.8%. We have 20% co-infection, HIV and HBV, and this is closely related to the epidemiologic history of HIV in Romania. And let me just take you back to the late 80s and early 90s, when I'm sure that most of you are familiar with the epidemiologic accident that occurred in Romania, when we had this cohort of children who acquired HIV infection parenterally. And almost 1 in 2 of them, so almost half of them, also acquired HBV infection. When looking at co-infection HIV and HCV, we see that the prevalence is 1.8%, but what is really worrisome is the fact that in a subgroup of intravenous drug users, the prevalence goes as high as 86%, which is a huge number. So looking at the prevalence of different subtypes, historically in the Romanian HIV cohort, those infected in the late 80s, all of you are familiar with the fact that we had predominantly F1 subtype, which was closely related to the sequences from Angola at that time. In new cases, we still see the F1, but we have started to see some subtype B, particularly in men who have sex with men, and we also see C and A. And again, in the specific subgroup of intravenous drug users, we see the circulant recombinant form 14BG. When talking about HCV, the data is quite straightforward. We virtually only have genotype 1. So we see genotype 1b mostly, some cases of genotype 1a, and only a few imported cases of genotypes 3 or 4. The main risk factors, as I told you, historically, we had the parenteral transmission for HIV infection long before we knew what HIV was and how we could diagnose it, how we could prevent it, and how we could treat it. And in new cases, we have seen, unfortunately, a lot of heterosexual transmission, despite all of the information campaigns and despite all of the population outreach campaigns. But this has slowly decreased over time, and it is increasingly replaced by intravenous drug users and by MSMs. Importantly, the rate of mother-to-child transmission in Romania has been consistently low, and this is a major issue for us because, as I told you, we have this cohort of children who were born in the late 80s and who now are 25 years to 30 years old, and they start their families, they want to have children of their own. And therefore, in the specific cohort of children, it is really, really important to decrease the rate of mother-to-child transmission. So what we have done is we have consistently started antiretroviral treatment in all female patients, particularly if they were pregnant. They had to be on antiretroviral treatment, and they had to have suppressed viral loads. We recommended elective C-section. We did 6 weeks of prophylaxis in newborns, and we also advised against breastfeeding. And through all of these measures combined, we managed to decrease the rate of mother-to-child transmission to keep it consistently below 4% and currently at 2.9%. Looking at HBV, we see that the main transmission route was unprotected heterosexual contact, and for HCV, parenteral and intravenous drug use. Most of our HIV-positive patients are currently on antiretroviral treatment, and as you can see, more than half of them are currently receiving 2 NRTIs plus a PI. 20% of them 2 NRTIs plus 1 NNRTI, and roughly 12% of the people are on integrase inhibitor-containing regimens. For HBV, you can see listed on the slide the types of treatment that are available and through the National Committee on Hepatitis. But the vast majority of patients are currently on treatment with entecavir. Treatment is reimbursed, as I said, by the National Committee on Hepatitis. Doctors have to submit the patient's medical records, and the medical records have to be approved, and then treatment will be reimbursed. In order for treatment to be continued, we're talking about analogs now, in order for treatment to be continued, then we have to submit periodic proof that viral suppression is obtained. For HCV, we do have direct-acting antivirals available, particularly the 3D combo for AbbVie, but unfortunately, we have only started to treat cirrhosis, patients with cirrhosis, or those with advanced fibrosis and with comorbidities that contraindicate interferon therapy. We are hoping that in the future months to years, we can expand the population of patients that we treat to also include lesser degrees of fibrosis, because we have seen that fibrosis is more quickly reversible if you start treatment earlier and if you don't wait for cirrhosis to appear. So I mentioned earlier that most of our patients with HIV infection are currently receiving antiretroviral treatment, more than 85% of them. This has been possible because we have this amazing national program for HIV infection where all treatment is reimbursed for all patients. And what is really specific for Romania is that we have never waited for the immune status to decline. We have never waited for the CD4 count to decrease dramatically, and once we diagnosed the patient and once we felt confidently that the patient can start a lifelong treatment and would have the best chance of being adherent and being compliant to that treatment, we started antiretroviral treatment in our patients. Most of them, more than half of the patients, are currently suppressed, but what's important to remember when looking at this slide is that we do have the cohort of pediatric children. They have seen all treatments come and go. They have started all types of antiretroviral regimen, and in this particular cohort of patients where they have had multiple failure to multiple regimens, it's pretty hard, and it's getting harder to keep them virologically suppressed even with the new drugs coming on the market. Unfortunately, we still see roughly 200 patients dying of HIV each year, dying of AIDS-related complications. When looking at HBV, we can see that roughly 1/3 of our patients are currently in treatment, and as I said, most of them are receiving treatment with entecavir, but also with tenofovir. And as I mentioned, viral suppression is required for treatment continuation. And before I finish, I'd also like to touch on HCV. We have treated almost 10% of the population infected with HCV, and we are trying to expand the number of patients included in the national treatment. You're already familiar with the rates of response to PEG interferon, so nothing new there. And for direct-acting antivirals, the response has been consistently above 97%. And with that, I'd like to thank you for your attention and leave the floor to the next presenter.